can talk a little bit about what we have seen pass and get other people's input, but that's not our principal agenda. The legislature will complete its work in about 7 hours and adjourn for the year, and leave a host of new assignments to the executive branch in Maryland to undertake, of which we are a part. So with that kind of introductory soliloquy here, welcome, and I'll turn it over to I think Anene is going to go through some introductions.
Thank you, Ben. Good evening, everyone. Thank you for joining the meeting this evening. We would like to remind everyone, as you heard, that the meeting is being recorded. Please contact the MHCC team with any technical issues. We sent out an email on Friday with the team's contact information. As a courtesy to others, please remain on mute when you're not speaking to reduce background noise. Staff may mute you if there's a lot of background noise coming from your line. You can also mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. The meeting facilitator will sequence speakers and may also call on people to speak to ensure that we have a range of perspectives. Please raise your hand by clicking the raise hand button under reactions at the bottom of your screen to ask a question. Another option is to enter your question into the chat box. So before we begin the meeting, I would like to recognize the work group members who are attending the meeting today, and I'll just go down the list of participants that I see on my screen. We have Dr. Dagarala, Ms. Christina Kaminsky, we have Dr. Bernstein, Dr. Marstella, Ms. Karen Lamb, Ms. Laura Russell, Dr. Michael Barr, Dr. Khanna, Dr. Lewis, Dr. Cheatham, Mr. Tyler Blanchard, Ms. Trisha Roddy, and we have MHCC staff as well in attendance, Mr. Mesta and Mr. Kenneth A. Strotman, as well as our consultant, Mary Jo Condon. If there's anybody I have missed who would like to introduce themselves, please introduce yourself at this point. And I see that I also left out Mr. John Miller. So that's another person. All right, hearing none, I will now turn over the meeting to our Executive Director, Mr. Ben Stephan, and our Workgroup Chair.
Okay, thank you, Nene. We've made some good progress, and what we're going to do today is walk you through the basic model and the several modules we've talked about pertaining to behavioral health services and GYN services that may be provided by primary care providers. I don't, before this meeting, want to label us as mirroring any other state, but I think Mary Jo is going to have some comments, Mary Jo and Melanie, of as we break into our presentations today on who we look a lot like. But it's important to keep in mind that we didn't start out thinking, let's mirror this, our objectives according to what's been done in other states, but it does kind of look like we are moving in one direction, which is I'll leave it to them to present the surprise to you. But looking forward to a focused meeting today, and clearly you'll want to encourage everyone to chime in with their thoughts and input as we go along.
Melanie, you want to bring up the...
Melanie, I'm turning it over to you.
Okay, thank you, Ben and David. So at this time, I'd like to review the work group activities through May, just to give everybody a reminder of where we've been and where we're going. Nana, can you go to the next slide, please? So at the end of last year, work group members responded to framing questions to inform a shared vision for primary care. In the first quarter of this year, we held meetings to develop an approach to track progress towards achieving that vision. We completed selecting the principles to define primary care at the last meeting. Today, which is the highlighted box, we'll discuss proposed models based on workgroup input. So we've tentatively scheduled a meeting for May 2nd to discuss the investment models if needed. And at this time, I'm going to turn it over to Mary Jo, and she's going to discuss the elements that we use to develop the primary care investment models.
Mary Jo, you're on mute, or you're just lip syncing otherwise, one or the other.
Now, how's that?
That's much better.
Great. All right. So we have 3 modules here. As you might remember, the work group wanted to measure core primary care services and then have the option to also include measurement of certain behavioral health services and OBGYN services. And so this modular approach allows us to see spending on each of these areas separately and then add them together or keep them separate as we see fit. So the first is spending on a set of core primary care services. And so in order to develop the code set to support this definition, we basically took a code set that was developed by NACESCO, which is a group of New England states that worked together to develop a sort of standard for measuring primary care investment. Now, they did this back a few years ago, actually right before the pandemic. And so there were some slight modifications that we made to the NACESCO definition to sort of update it. The first thing that we did was we expanded the list of telehealth codes included and also added some remote patient monitoring codes, the sort of the primary care physician portion and other primary care service portions of those codes. And then the second change that we made was on the taxonomy codes or the primary care provider specialty codes that we used. So we also used NACESCO as the basis for the primary care taxonomy codes, but we also wanted to reflect the work group's interest in team-based care, and so added some of the clinical nurse taxonomy codes as well to that. When we look through the results in just a few moments, you'll see that for each one of these modulars, we're sharing with you the results when we did not restrict by place of service code. So all place of service codes were included. And then also what we're calling sort of a narrower definition of place of service codes, where we're removing certain care settings, including retail clinics and urgent cares. Any questions on the core set of primary care services and specialties before I move on to behavioral health? All right, seeing none. On the behavioral health side, you might remember that the work group really wanted to try to isolate behavioral health services that were provided in collaboration or integrated with primary care. And so we used a basic code set of outpatient behavioral health services and then applied a taxonomy structure that said that either the PCP's, the servicing taxonomy needed to be a primary care specialty, and so basically come from that core set of primary care provider specialties used to measure primary care, or if it was a behavioral health specialty in the servicing taxonomy, it needed to be a primary care taxonomy specialty in the billing taxonomy. So that billing taxonomy of primary care is how we're making that tie to behavioral health integration. This is very similar to an approach that was used in Colorado, and you'll see the results here in just a few moments. Any questions on that before I move on to OBGYN?
I don't think we have Chad Herman on the call today. Do we? Is Chad here?
We have not seen him come on board.
Okay. Yeah, and maybe as a proxy, I can ask Tyler to chime in if he has a perspective on this, that in theory, insisting on a behavioral specialty in the servicing taxonomy and a PCP specialty in the billing taxonomy code should work. But there may be, more informal collaborations that don't pick up that. Any thoughts on the approach we're using, Tyler, if you can hear me?
I can. Hi, everyone. I think some of the informal collaborations you referred to, Ben, would make it difficult to pick some of these activities up in the claims data, especially as it pertains to MDPCP, where there are non-claims-based payments happening that are covering kind of variable services that don't get billed individually. So there could be a challenge there.
Thank you. Dr. Bernstein.
Yeah, I think those would be hard to quantify and would be missed. I mean, my gut sense is they're probably not a huge volume. I personally wouldn't be uncomfortable if they're, unless we have evidence elsewhere.
I will just note that the group also recommended that we include non-claim spending on Medicare as soon as possible, and also next year work to define an approach to including non-claim spending in the commercial market. And so I think that those payments that Tyler referenced and probably make up the bulk of payment for these types of services will eventually be captured. It's just that today's discussion is really focused on the fee for service.
Dr. Bernstein, your hand is raised.
If it is, it's an error. I'm sorry.
Okay, that's all right. Okay, Mary Jo, proceed.
Sure. And then the last modular is for OBGYN services. And when the work group weighed in, they expressed a preference for including a broader set of OBGYN services, including prenatal care and deliveries, but not including OBGYNs, really referring back to that core set of primary care specialties. So for example, we're including when a baby is delivered by a family medicine physician, but not when delivered by an OB.
Right. Any questions on that? I think we worked on that quite a bit over the last 2 meetings, so I assume there's pretty good understanding of that. Dr. Connor, you came on the camera. Did you want to say something?
Just wanted to say I agree.
Okay.
Dr. Marsteller has her hand up then.
Dr. Oh,
Jill.
you're at the top of the screen. That's the disadvantage of being at the top of the screen. Jill, I can't see your hand. Now I do. Go ahead.
I was just checking in terms of the core work, did we decide that a well visit to the GYN counted as primary care?
No,
We exclude that just because it's a GYN.
correct.
Yes.
Mm.
You think we ought to rethink that?
Well, I mean, I look at it, I feel like it's primary care, right? Just because it's about a different part of the body, it's not counting as primary care. I mean, I get that it's being provided by a GYN, but to me, that's primary care. That's basic health, right? And we're sort of saying that it doesn't count because it's a lady's parts. I mean, like, I don't know. I want to throw that out to the group and see if there are reactions.
This is Dr. Lewis. I won't say it's because of the lady's part. I will say it's because the GYN. So I just want to make it real clear. It's not about, because I'm a family physician, I do GYN exams. So I feel that we should be doing them. But a lot of my patients prefer to go to a GYN specialist. And so in response to you stating, I don't think it's so much the lady parts per se. I think it's just because it's a GYN practice. And I assume that's why you're excluding them, because we are not fully aligned with primary care services.
Yeah.
And forgive me, I
that's
missed the
pretty
meeting
well put.
last week. Go ahead.
Yeah, go ahead.
So Ben, Dr. Barr has a question.
Dr. Barr.
No, I just think a clarification going on with Dr. Lewis. I think, Jill, the issue was not that it isn't a valuable service, a highly valuable service provided by OBGYN physicians and nurse midwives and so on, but that we were trying to characterize what is primary care and then sort of as a bundle, and then that's individual service. And we had a lot of conversation about that. So please, and I made a point to say, it's not a matter of a value judgment. It's a matter of what we want to count in this model, in this modular format. This to be really, really clear.
And Ben, Dr. Barr's comment may address the couple items in the chat. Perhaps anyone in the chat who doesn't feel that it's been addressed could raise it with Ben now.
Oh, I see.
What about OB services by a nurse midwife?
Those would not be included.
Right.
For the same reason, right? Those are valuable services. We should count them and measure them where they're being provided. But if we're looking at investment in primary care clinicians and the full range of stuff, longitudinal across all conditions, chronic, acute, preventive, and so on. I think that's the difference. Again, not a value judgment, just to how we're parsing it.
Ben, I think Dr.
Laura, I think asked the same question. I think.
Dr. Khanna has a hand up too.
Wow.
Can I
Go
go,
ahead.
Ben?
Go ahead, Dr. Khanna.
So I think I just wanted to add that well visits for women have largely become very much more like a well adult visit. You know, a lot of it is taking care of their hypertension and diabetes because we're not doing as many pap smears, especially in women who are over the age of 30 or doing a pap smear only every 5 years. So it's really not a classic GYN exam the way it used to be in the past. It's really more like a well visit, you know, just examine the woman. So it's different. And in a primary care setting, the management of all of this chronic disease that goes on is somewhat different from what happens in a gyne office. So I think there are some key differences in the way a well woman visit is conducted in primary care versus the way it's conducted in OB-GYN. There's a significant difference. So I think including only the primary care piece in this discussion on reimbursement does make perfect sense. And I just wanted to say that.
That's
thank you.
underscoring what Dr. Barr is saying, I believe.
Yeah. Laura, you also had a comment in the chat.
I think that's what Dr. Khanna was answering.
I think she was responding to what Laura had said, but
Dr. Conway then.
yeah, okay.
Yep. Dr.
right.
Khanna answered my question. Thank you.
Thank you.
Dr. Conway has her hand up.
Just one question in terms of the direction is there intended to be, and I'm sorry, I guess, again, I was traveling in the last meeting, is there intended to be some directionality related to this? Like, do we want more of women's health care covered in the PCP visit? And I asked this in line with conversations that were had earlier in the series about, you know, procedures being done in primary care visits or things that aren't necessarily traditionally primary care, but could be, because if you think about sort of fertile women or women of childbearing age, that is a lot of their care is done by an OBGYN, but could certainly be done by an internist or family medicine doc or what have you. So if we're trying to be inclusive and make a suggestion that should be more included in primary care, I could also see why you might make that distinction. But I don't know if that conversation was had in the last session at all.
So I'm going to actually go over a slide in just a minute before we walk through the models. And I'm going to walk through all the key takeaways that we got for each of those principles we discussed. So I that might be helpful. I think that might answer your question, because what we got from the group where we think they tended to support was only those core those PCP services when they were done by a primary care provider. So Mary Jo, I don't know if you want to kind of expand on that at all, or if that answers it.
I think that one of the things that the group has shared is an interest in, and I think this came up more when we were going through the discussion on the framing questions, is an interest in primary care, performing services when appropriate and possible, and when they're able to provide the best service for the patient. So I think that that has been an interest of the group, but I would ask the group to correct me if that's incorrect.
Dr. Khanna, your hand is raised again.
So I just want to reiterate that family medicine routinely is taught and does almost all minor GYN procedures. So for example, abnormal PAPs are managed with colposcopies and biopsies in family medicine, as are most reproductive procedures for LARCs are all offered in family medicine. And at our site, we are even doing medication abortions and all of those things. But for the most part in the community, you will see a lot of older, especially family physicians, who do their own procedures in GYN. Again, it's a question of who does them, I think. It all comes down to who does them, but they are trained and quite capable of doing all of these things.
Other perspectives? Okay, Mary Jo, do you want to proceed?
Yes, I think that that's all that we had on this slide, and I believe I'm turning it over to Melanie for the next slide.
Yeah, do you want to kind of, I always look at the place of service. Can we go back there?
Sure, I can
Just
talk
be
a little
sure
bit.
before we jump into this, what we mean.
Yes. So claims have a code on them that designates the place of service or the care setting in which the care was provided. That might include office or hospital or retail clinic or FQHC. What we did here, and what Ken and Ose and the MHCC team did, was they ran this data, these exact same CPT codes and taxonomy codes, a couple of different ways. And what you're going to see today regarding place of service is two of those ways. One is to include all places of service, to not discriminate based on the care setting or the place of service where it was delivered. The second approach removed certain care settings, including those related to retail clinics and urgent cares. And so in a minute, Ken is going to show you sort of the impact of those differences. So I don't want to take away the excitement, so I won't go much further, but
that's all I needed from you. Thank you. I mean, I think we haven't finished talking about urgent care, I suspect, but I want to flag that in the narrow definitions, urgent care, and maybe more appropriately, retail clinics are not included. Okay, I'm turning it back to you, Melanie.
Yes, thank you. So in just a moment, Kenneth is going to be walking through the actual primary care investment models with you. But before we do that, I just want to go over again what we discussed during the 313 and 327 meetings. And then if you could bring up slide 2 from the models, so that we can go over what we discussed. So really, what did we build these models based on? What were those decisions that were made from the principles in the table that we talked about? So the first was that the work group supported a modular or stackable definition, which you're going to see today, and we've referenced a lot, is the modules. They supported, or you supported, intrastate geographic reporting, aligning with other state and national definitions as a secondary goal, but not an immediate priority, because a lot of people feel that Maryland is unique, which it is. And so we did come up with something that is not exactly what everybody has, but it is unique to us. An expanded list of defined primary care services and providers, which Mary Jo talked about in detail, include basic outpatient behavioral health services, such as those performed as part of an integrated behavioral health arrangement, which she talked about as well, including the broader set of OBGYN services, such as prenatal care and deliveries, when it's provided by a primary care provider, excluding pharmacy from the denominator, and including Medicare fee-for-service, non-fee-for-service for now, which is the non-claims-based payments. For example, the care management fees that are provided through MDPCP is the biggest example I can think of. And then measuring other payers when it's possible. We had a discussion at the end of the last meeting about we're starting to collect this information, but we don't have it available for all the commercial payers at this time. So that's kind of a summary of the principles and the tables that we talked about at the last two meetings that went into developing these financial models that Kenneth is going to go through. So Ben, do you want me to stop and ask for questions now, or do you want Ken to step through the
I think we should stop for questions now. And I'll ask the first one. I think in Maryland, given that we are, a heterogeneous state, both in terms of geography, but in terms of race and ethnicity as well. What other states have made headway, Mary Jo, in terms of looking at geographic variations or other definitions that might be meaningful within their methodology? Are you aware of who's moved that effort forward? And I think we're going to find, given the struggles on the Eastern Shore and to some degree similar problems in Western Maryland, that the share of primary care spending might display some significant regional variations. Go ahead.
Sure. So I can tell you in Delaware, we do look at primary care spending by county, but only claims-based primary care spending, so not non-claims, or also known as non-fee-for-service. This is, we're also supporting the work of the Office of Healthcare Affordability in the state of California. They are very interested in looking at geographic variation, as you might expect, because they have such a broad geography. It's been, I think, less of a priority in some of the other states. And I'm not exactly sure why, because I do think it is really important. And I think its importance is growing, particularly as we get to more sort of granular geographies, because of the desire to really look at this as a health equity issue. And I think looking at primary care spend through a health equity lens really requires us to look at differences by geography. So I think you're a leader here, but I think it's an important way to view the data.
And Dr. Russell.
Dr. Bernstein.
My recollection of the discussion about being able to layer and vary interstate geography wasn't so much for an emphasis on looking at equity issues, but accounting for difference in practice structures, particularly primary care, in different areas, and also the shifts that might occur as we, develop a program. So, I mean, that's just my recollection. It wasn't so much, I mean, there's obviously an equity piece, but I don't think that was, by my recollection, the primary motivation.
Yeah, I mean, I think we spent a little time speaking about this, but I think it was both. I don't want to weigh them as 60-40, 70-30, 70-30 or something, but yeah, I think there were perspectives offered on both dimensions, both purely geographical variations, but I think access by different populations within the state were something that at least some people thought were really important, as do I. Dr. Russell.
Yeah, first I apologize for missing the last meeting. I want to speak to the pharmacy spending. I saw the video, the recording, and one thing I did not see, and maybe I missed it, in regards to removing pharmacy spending from the denominator, I just kind of feel like you're missing an opportunity to show how primary care can have an impact on pharmacy spending. I mean, this is all hypothetical. I'm assuming that a patient who's plugged into a primary care facility or provider, that the pharmacy spending may be less than an individual who is not. So I think that would be a great way to demonstrate the value of having a primary care provider, especially in a setting where we're seeing a increase in pharmacy spending. So I'm not sure if you all had a discussion about that. I'm not sure if you're able to operationalize that. And so, yeah.
Yeah, I think that's a good point. And I don't think including it or not including it would prevent us from in a more focused, assessment to do that. But I'll ask Mary Jo to kind of lead us through our thought process on, how we got to the point of excluding it. Go ahead.
Sure, happy to. So the first thing I'll note is that the inclusion of pharmacy in the denominator would not show us whether or not individuals who were under the care of a primary care provider had higher or lower pharmacy spending. So we would need to do a separate analysis of that. I do think that that's an interesting question. I think it's also an interesting question to look at things like, proportion of days covered and other sort of, quality assessments of adherence, et cetera, to see if being under the care of a primary care provider improves adherence, for example, which I think would be a really interesting study. The reason why the work group decided to exclude it is largely because it can be challenging to get an accurate number of pharmacy spend. So because of the way that pharmacy services are paid for, the dollars associated with rebates are not included typically on a claim. That would require a separate data collection. And rebates, depending on the prescription, can be, on average about 25% of overall drug costs. And unfortunately, they're not evenly applied. It's not like every drug is roughly 25% less, and we could just sort of, reduce all the pharmacy spend by 25% and know that we had an accurate number. So because it's really difficult to get that accurate pharmacy spending number, many measures of primary care investment as a percent of a total amount rely on the medical total in the denominator rather than medical plus pharmacy, because there's a goal to not sort of have an inflated number in the denominator.
Thoughts, Dr. Lewis?
No, I'll just say thank you. So I gleaned that from the recording, but I didn't hear anything about opportunity to demonstrate how we impact pharmacy spending. But Mary Jo, you explained the complexity of it all. And I just hope that later on we can circle back and see if we can tease that out and demonstrate that impact. So, but I do understand as to why we're excluding it.
Dr. Conway also had her hand raised.
Yeah, just a quick question for the pharmacy spend when you're thinking about Medicare. Does that exclude like any Part B and Part D type spend, or would it only be like anything that's under sort of like an infusion? Where would that be called out as well? It's excluding everything, right?
No, actually, that would.
We would. Yeah, I think we would for Medicare Part B include physician supplied pharmaceuticals in the Medicare assessment. But not the Medicare Part D, which is consistent with the way the total cost of care arithmetic is run here in the state as well. Because Part D is
Okay, so it's, okay.
not included. And I think the points that are being raised are good ones. And like, some of the other questions, this is not the only kind of assessment we would be anticipating that I think the starting framework is not necessarily where we hope to end over the course of a few years, but I think trying to get a good kickstart in terms of a framework is what we, consistent with the principles we laid out, was what we were trying to do. But I think as we move through this, happy to kind of open up some of these discussions again too, as you get to see real numbers.
So I just want to, I'm pretty sure you're all aware of this. So in regards to infusions, if I'm the provider doing the infusion, yes, that falls under medical. But if I give that patient a prescription to go to the pharmacist to get the medication and bring it back to me for infusion, then that falls under pharmacy spending. So I'm not sure if that's going to muddy up things here when you're incorporating pharmacy from the infusions, I mean, it being infused versus it being prescribed, then a patient brings it back to be infused. So just want to bring it to your to your attention.
Yeah. Thank you. And other questions before we move on? Melanie, is it any last points?
No, we'll be talking through some things during the next steps, but for right now, why don't we let Kenneth run through the numbers and show everybody what the results were, the financial results.
Go ahead, Ken, you're up next.
All right, thanks, Ben, and thanks, Melanie, everyone. So before we get into the numbers, just want to give you some context on the place of service for the narrow, which is a limited place of service, as Mary Jo said, excluding the retail clinics and urgent care centers. So, however, there is a lot of place of service here that are included in the narrow definition. However, only a handful of these place of service that really drive the primary care spend. Highlighted here, office visits, on-campus outpatient, hospital, and telehealth. When we look over on the right, we categorize these place of service as top 3. As office visits, we see that it's at 82%, and this is the frequency of services. The on-campus outpatient hospital is at 6%, and the urgent care facility, which is not included in the definition for narrow, is at about 5.9%. Well, when we go down to the all other place of services, we see that the telehealth, which is noted here, in at 5.4%, and then everything else, is at 0.6%. So we can see clearly that most of the place of services here is only a handful of them that are the drivers of the primary care spend.
And remember, we're looking at data from 2022, and we're looking at commercially insured populations. So obviously, if this was a Medicaid population, we might see more federally qualified health center volume. We might see, if it was Medicare, a place of service such as assisted living facility with the commercially insured, which we have no age screen, so people continuing to work past 65 are going to be in this population, but those numbers are relatively fewer than in the Medicare population over 65, for example. And was this not 2022, but rather 20 or 2021? We certainly know that telehealth would have been more significant. We think telehealth is reaching towards an equilibrium, far down from in the height of the pandemic, but still far more significant than it was in the pre-pandemic period. Naturally, if we were to overlay a Medicaid population on these place of service codes, they would look different, and likewise Medicare. But one question, particularly for the academic practices, we did debate as recently as about 45 minutes ago about whether we wanted to include campus-based facility charges, which we think makes up, a portion of the on-campus outpatient hospital volume, and we decided that it's probably appropriate to include the facility fee that may be billed separately in campus-based primary care, but wanted to at least pause here and get anyone's thoughts about that before we proceed.
Oh, sorry, I didn't raise my hand. I'll wait.
That's okay, Dr. Conway.
Okay, so for that one, you're saying, so a hospital-based clinic, so you're doing both the professional fee and the facility fee is what you're trying to include within this in order to capture the overall cost of that primary care visit. I would think that feels like it would be the appropriate way to actually capture the all-in cost of that, right? Because I do think those visits otherwise would appear perhaps slightly cheaper, even though in reality, the overall spend is much higher because you're paying for that facility-based element as well.
Yes, that's our thinking, that it is, that it would be appropriate in this particular case to include the facility fee. Tyler, you had your hand up, but now it's down. I don't know.
Yeah, I was actually going to say the exact same thing, but probably not quite as eloquently. So definitely agree.
And Mary Jo, correct me if I'm wrong, but the other states that have engaged in this enterprise have also, pretty much followed this line of reasoning that it should be included, as Dr. Conway noted, a more expensive service, but nonetheless, inexplicably primary care.
Yes.
Okay, go ahead, Ken. Back to you.
All right, just a brief note that these distributions are based on the 2021 data.
Excuse me. Okay, I thought it was 2022. My mistake.
All right. So next slide, please. So the first scenario here, we have a scenario one, the based scenario, where we look at the core set of primary care services with the core set of primary care providers. And in this exhibit below, it shows restriction to the place of service. That's means all, and then we have the narrowed, which is limited. So we see for all place of service, see in 2019 at 6.4%, and in 2020 it decreased down to 5.9%, and then it continued to decrease in 2021. Also, for the narrow place of service codes, we see the similar pattern as far as direction is concerned at 6.1 in 2019, 5.5 in 2020, and 5% in 2021.
Dan, do you have any explanation why is the primary care share trending down, both in terms of the overall and the narrow definition?
Yes. So when we look at the denominator for that is all medical spending, we see that it's increasing at a higher rate at about 16% than the numerator, which is primary spend at about 4.5%.
So it's a simple case of other services are growing more rapidly than primary care services, and anybody find that result consistent with what you're seeing in your own environment, or surprising? Dr. Conway?
Sorry, me again. So I think that's not necessarily, I think, overall surprising. I guess I'm more interested in the spread, the relative spread between narrow and all in terms of the categories there, and that, you know, both are trending down, but the spread is growing between them. And I wonder, just looking at the categories before, if that's primarily driven by an increase in urgent care providers, and that is sort of a growth strategy, and particularly around COVID and other things, a lot more use of urgent care. And so just imagining that that's the principal driver of that.
I think that's a good hypothesis. Dr. Bernstein?
I would agree and add another step that it may be limitations in primary care setting availability due to staffing and other post-pandemic situations that drives even more to urgent care, which would explain both the trend and the differential, as Dr. Conway is saying.
And then could Mary Jo provide some perspective on this nationally with her work?
Yeah, Mary Jo, do you have any data on what other states are seeing?
Sure. So it's consistent with this, in that essentially, you know, the overall cost of care is often increasing at a faster clip than the portion of spending that is going towards primary care. And so as that occurs, your percentage of total primary care spending is going down. Similarly, we are seeing increases in use of urgent care. Other states are seeing increases in use of retail clinics. That didn't surface so much in the Maryland data, so that's kind of interesting. And then, of course, there is, primary care access issues that we see across the country.
Yeah, and we're now merging into the area where we're talking, hypothetically, but keep in mind that with the global budgets, hospital revenue was relatively stable during the pandemic, and that stability, whereas other types of services, driven by patient preferences, may have meant that as a consequence of inpatient and outpatient hospital services were driven by global budget requirements, and many times health systems had flexibility to raise the unit cost to meet global budget obligations, that may have be a factor in these downward trending fluctuations as well. I think that's in the hypothesis area. I don't know if William Henderson is on, but if you are, William, do you have, am I nuts here, or is that a possibility?
And Ben, I don't see William.
Yeah, I don't see William. So anyone else want to venture a thought here? Seeing none, but it is something that I think warrants some further exploration on our part. And Ken, you don't have breakout numbers on the share of total spending that's attributable to hospital inpatient and outpatient in this 3-year spread, I assume.
Not immediately, Ben, but we could get that quickly, but
Yeah.
in the data, not readily tonight, but we have it, we could get it.
And I think Dr. Bernstein brings up a great point in the chat also, and that's also something that we're seeing on a limited basis in some other states, where some of the primary care spend is shifting to non-fee for service, and it can make a slight adjustment in the amount of fee for service dollars.
Yeah, important to remind everyone that right now, Kaiser utilization is not showing, correct, Ken?
That's correct. We don't have the claims.
We're working on that.
We're
But
working on that, yes, very successful.
okay, Ken, back to you.
Can I ask I'm sorry, Ben, can I ask a question?
Sure.
So is there a way to look at primary care spending per just the population in Maryland? And see how it does over time? Because I just think looking at it from the standpoint of spending per population and seeing how that investment changes over time could be helpful as opposed to the total spend, because then that way it isolates anything that may be going on with global budgets and just looking at what does the expense look like relative to just that investment in people.
Yeah, we can calculate some PMPMs, correct, Ken? That would make that.
That's correct, yes.
Okay, thank you.
Go ahead, Ken.
All right, next slide, please. Okay, so on this scenario 2, we look at the behavioral health model. So in this module, it includes the basic outpatient behavioral health services, such as screening, collaborative care, or brief counseling sessions when provided by a primary care provider or integrated with primary care. So when we look at the results here without any restrictions on the place of service, we see, and also the narrow, we see that there has been no change across all years for both narrow and no restriction on the place of service at 0.1%.
Yeah, I mean, what's telling to me is we've talked about this, but it, in terms of practice, it doesn't appear to be, moving as dramatically as we might hope in terms of these integration of behavioral health services provided by primary care providers or closely linked behavioral health specialists. Kind of undramatic here at this point. Any thoughts on how that? I mean, keep in mind that if we included behavioral health specialists, the share would jump pretty dramatically, but we're not doing that. So don't want people to get lost and say, oh my God, there's hardly any behavioral health services being provided to the privately insured. That's it's a very narrow slice of what the behavioral health care services are in the state. Questions? And I think, it shows we have a long way to go here, more than anything.
Ben, this is John Miller, if I may jump in. Once again, as I observed, I think the last meeting, there is a regulation or bill that's been passed or is being passed even as we speak in the legislature that will be reimbursing for collaborative care in the Medicaid setting. And although that won't affect this really, although there may be some spillover from that, I anticipate that we'll have an impact in the uptake of collaborative care codes, if that makes sense in this, in this discussion right now. Thanks.
Sure. Tricia, do you have any points on that, or what's your thinking in the Medicaid population? Are we going to see a dramatic increase when we move to Medicaid?
I'm sorry, Ben, when we looking at the behavioral health?
Yes.
Well, we're going to be covering collaborative care. So starting in July 1st. I'm not sure how much it's going to increase it though.
And it's important to keep in mind that, behavioral health by and large it would be carved out of the MCO arrangements. So it is a little more challenging to embed that in a primary care practice.
Well, the collaborative care piece is going to be the MCO's responsibility. Those codes will be the MCO's responsibility.
Okay. And that bill is passed.
And we have the funding for it from TBM.
Always good to know. All right, Ken, continue.
All right, next slide, please. So we on to module 3. We look at the OBGYN module. So in this module, we include a broad set of OBGYN services, including prenatal care and deliveries when provided by a primary care provider. So when we look at the results, all versus narrow, we see on the all pretty stable throughout for 2019, 2020, dip slightly in 2021, and then when we go down to the narrow, it's the same for across all years from 2019 to 2021. So this is the impact including and services when it's provided by a primary care provider.
And again, very little of these services, at least in the 2019 through 21 data get picked up. Okay, any questions on that? Seeing none, go ahead, Ken.
So next slide, please. Next slide. So we move to the appendix where we have, more detailed information. Don't want to go through all of these, busy slides, but this first slide depicts the core set of primary care services that we talked about earlier in the prior slides. And these are the list of primary care services under the, for as far as CPT codes are concerned. There are about 38 CPT codes here.
Okay, go ahead, Ken.
Next slide, please. And then these are the corresponding core set of primary care provider specialties. They are about 19 categories here. The first set show physicians, which include family medicine, general internal medicine, pediatrics, general practice, and also geriatric medicine. And then goes down to chronic health, family health, urology, proctology, pediatrics, and school. And then we go over to the tables on the right, and these are restricted by only for home health and hospice procedure codes. So for family medicine, we have hospice and palliative care, internal medicine, hospice and palliative medicine, and then for pediatrics, the hospice and palliative medicine. And then for the last table, these are restricted by revenue codes for clinics, professional services, and these are the categories that are listed.
And of course, we don't have critical access hospitals in Maryland, but are we counting patients who say visit a critical access hospital for a primary care service, Maryland resident, but getting that service in West Virginia, say hypothetically? Or do you know?
No, I don't know that, but it has to be in Maryland residents.
It has to be a Maryland resident, but it could be a service.
Could be, yes.
Provided outside.
Yeah, because these are not Maryland, didn't depict this by Maryland providers.
Correct.
That's correct.
A question for you, Ken, on the nurse practitioners. We have a fairly good supply of nurse practitioners in the state, but it's my understanding that the trend in the employment of nurse practitioners is increasingly going to specialty care. So we're able to separate nurse practitioners by the specialization that they report in the NPES data.
Yes, we could, yes.
And And when we list those four categories, adult health, family, pediatrics, and primary care, those are specific MPES definitions that
That's correct.
that are screened.
Yes.
And we wouldn't be picking up nurse practitioners who are providing services, say, in a cardiology practice.
Well, we have a nurse practitioner general, so so that could be suspicious.
Okay, right. Questions here on the specialties? Dr. Bernstein.
On the core services, maybe I just didn't get to read fast enough, but when under immunizations, is that inclusive of both immunization administration and vaccine material?
Yes.
And do we account, maybe this is actually one of these non-fee-for-service thing, but the value of VFC provided vaccines, is that included in these models?
I did see Mary Jo was shaking her head. What were you shaking your head about?
And correct me if I'm wrong, but I think that we only included vaccine administration, not the cost of the drug in the vial. Is that right?
Just the vaccine administration, I believe, yes.
Yes.
Is that for VFC or for all immunizations?
VFC. So that would be for all immunizations, I believe. I can send you the code set, Dr. Bernstein.
Yeah, I would argue against that approach. The vaccine material should be included in the core services.
So I think that's a question, for the group's discussion. I can share why it's typically not included. And that's because it's typically viewed as more of a pass-through. So essentially, you're not really investing in primary care. You're more investing in a medication or in this case, immunization that is just being administered in the primary care office. So for example, if the primary care office had a pharmacy that supplied hypertension medication, we wouldn't include that as a core service. But obviously it's to the group's discretion what the group prefers.
Any other thoughts on that?
But the value of the vaccine, even if it's a pass-through, is still a preventive care, primary care resource that's being spent.
I suppose it kind of falls into the physician supplied drug category too. We could think of it in the same way. What's the difference? Does anyone want to distinguish that for me? Part B drugs. Dr. Lewis, do you have a perspective? I know you had some.
Yeah, I was coming to that conclusion. It's like, how can we exclude vaccines if we already just said that we're going to include the infusions? And so I don't know how you capture that cost, but I think it should be included as far as immunizations and the expense.
Not to interrupt, the one distinction I would make is that the infusions are not included in the numerator. The inclusions are included in the denominator. So the vaccine, the infusion cost related to the cost of the drug in the infusion is not included as primary care spend. And I think Dr. Bernstein's point is that in the case of a vaccine, the cost of the vaccine, what's actually in the vial, should also be included as spend on primary care.
At a gut level, how does everyone feel if you lopped off flu shots as a flu vaccine as a primary care service? Doesn't Doesn't seem right to me.
Anybody, other thoughts, Dr. Conway? Were you raising your hand or maybe scratching your head?
No, I wasn't, but yeah, just itchy. No, I think to that question though, so still a professional fee associated with it, right? If they're still coming in for a visit, if they're getting a flu shot or if they're getting, you know, Pneumovax or something else. So it's not, that's still being captured from the professional services perspective, just not the actual cost of the drug itself.
That's correct.
So I think that's the part we want to capture. It's the provider element of it that it feels like the most critical piece to capture.
Not to get into the weeds about it, but there actually is a component of the vaccine cost that is a storage, handling, management, that is a provider cost and service, which is separate from the actual administration. But that's probably a little too microscopic.
Dr. Barr, did you have a point?
Really interesting conversation. I just had a question that how would you handle vaccines for children? Because those, right, aren't those supplied? They're not purchased? Or am I get that wrong? If we were to include that, Jeff.
Yeah, I think actually, and just in the course of this discussion, I realized that's probably an example of a non-claims based expenditure that we haven't accounted for. It's a federal expenditure, but it is an expenditure.
Somebody's paying for it.
Primary care, yeah.
I think Mary Jo, to your point, the professional fee is included. It's the supply cost that's not. So if we take that and generalize it, are we going to try to include all supply costs in the office? I mean, or is vaccines a special case where we should include it? Because there are other supplies that primary care has, and so it just wanted to see where that generalization holds.
Mary Jo, do you have any comments? I don't, I mean, I'd have to think about this myself.
So it's interesting. Often primary care providers do not want to include the cost of the vaccine itself because there's a concern that there's not any additional benefit provided to primary care infrastructure as a result of, or to support primary care access as a result of including that, because essentially those dollars just pass through the office and go to the vaccine manufacturer. So that's sort of typically the argument for excluding them, in addition to the argument that Dr. Barr just mentioned, which is, you know, it's sort of one supply cost. And so that's why typically and also, by the way, to Dr. Russell's point, those infusion drugs, those are also not included in the numerator. It's really sort of looking at service provision and the costs in the associated payments for service provision.
Then Dr. Dugarala has a comment. Do you wish me to read it or do you want to note it?
Dr. Dugarala, do you want?
Yeah, I was just in agreement that I think the vaccine administration fees are part of what we do as physicians. It's a service that we provide, but the vaccine costs can vary greatly depending on what kind of vaccine it is. You know, if you include like shingles vaccines, I mean, those can be like $200, sometimes more. So I think those should be included as, just as we would exclude prescription drugs, we should exclude the cost of the actual vaccines. But the administration fees I would consider as part of, you know, regular primary care services.
Thank you. Dr. Marsteller, are you? Did you have?
Yeah, I'm here. Yep.
Oh.
Yeah, I mean, as far as an opinion, I mean, I think that a drug is, to me, any medicine or drug or vaccine or any of that is not primary care. It's a commodity that is used in primary care or could be used elsewhere. So to me, it, definitely belongs in the denominator, but not in the numerator.
Dr. Cheatham, are you on? I hadn't heard from you. I wondered if you had any thoughts on this.
I'm on. Can you hear me?
Yes.
Yeah. No, I've been agreeing to what we've been discussing on this. So I think we're in a good place. It's been a pretty robust conversation as it relates to vaccines and the FC. So I think we're in the right place. I don't have any strong opinions against where we're going.
Okay, all right. Thank you. Ken, back to you.
Okay, next slide, please. So we went on to the behavioral health services. This is a whole array of services. I'm not going to go through them all, but these what they are.
And Ken, can you give us any insight? I mean, as some of these are, in my judgment, would most even, primary care physicians would feel uncomfortable about doing some of these services. But as we did with the point of service, there wasn't a lot of behavioral health service appearing, but do you or OSE, can you give us an insight into what did appear? Because each of these are a unique CPT code, correct? And
Yes.
you don't have that in front of you.
I don't have it in front of me,
but
they could get in the next 10 minutes.
And where did we come up with this list?
That's probably a question for me. So we developed this list based on lists that were in use in several states, Oregon, Colorado, Massachusetts, those were and also Delaware. Those were the primary lists that we consulted.
Mm-hmm. Okay. Yeah. I mean, I think it would be just for our own, familiarity with, this module that we look at what of the primary care providers that are doing this, what are the codes that are actually appearing, give us some insight into, how the integration of behavioral health services into a primary care practice is actually diffusing.
Then we can get this and provide it to the group at a later date.
Yeah. Anybody based on experience want to venture where the concentration of these services might fall? I mean, I was thinking we would probably see a lot of medication management coding, but I don't even see that.
And John has his hand up.
Yeah. Okay, John, and then Dr. Khanna.
Thanks. I'm sure this is a dumb question, but is there a specific code here for collaborative care, or the collaborative care codes somehow embedded in this list?
If we're going to rely on Tricia to inform us, I don't know. Good question. We may have to get back to you on that. Tricia, are you still available? She may have had to drop off. It is sine die. We'll have to get back to you on that, John. Dr. Khanna?
So I wasn't sure I understood your question, Ben, but the answer to John's question is right here. It's provider works with outside agencies, employers regarding patients' physical environment to manage psychiatric patients' medical care. That's part of collaborative care right here. And then further down it's the same. So if your question is where are these delivered, is that the question, Ben?
So the question is, I mean, we have a list, and the list came from another state. But if we actually did look at primary care providers using the limited specialties we had, or we looked at behavioral health providers that were physically a part of a primary care practice, where would we see the bulk of the codes being used? Is it I'm just guessing that, given the integration of behavioral health services into many primary care practices is just at the outset. I wouldn't want to hazard a guess other than to think, that medication management and short-term assessments are psychological testing, maybe other codes, but I think we can. It's not a question that we can just guess at. We need to go back and look at this, because there are a host of codes that are judged, at least by the work in other states, as potentially appropriate, but what's happening here and now.
So I can tell you that TMS, so some of these things, diagnostic evaluation, diagnostic eval with medical services, psychotherapy, family psychotherapy, all these things are done in primary care. But this TMS, it requires equipment. And so these two TMS codes are unlikely to happen, and including the third one, where you apply electric current to the patient's brain and all this. So you need anesthesia for all these things, and you don't have that in primary care. Hypnotherapy is part of primary care. Some people are trying to learn hypnotherapy and use it, especially as the payments for alternative therapies are expanding. People are trying to do that. And then preparing report on mental state for other providers. All these things are done. And then on the other side, where you have developmental screen, neurotesting frequently takes so much time. Primary care almost never does it, but I guess if they wanted to, they could.
Okay.
And some of these other assessment types of things do happen in primary care. And some of these where there's adaptive behavior treatment protocol, where you're working together with a psychiatrist, these larger documents here, all of these things are done. For example, if you had a patient who has, say, schizophrenia with, pretty decent hypertension or CHF or some such, all of these things would happen in primary care, because you have to co-manage with psychiatry. And somewhere I saw you could start addiction protocols in primary care. So that is increasingly being encouraged, especially the buprenorphine ones, which people are getting trained now more and more, now that some of the barriers have been removed. So a lot of these things are done in primary care, depending on your interest and your population that you serve. I think TMS, maybe no. And the electric current stuff, probably not happening.
Dr. Bernstein, you had a note in the chat. Are those codes that you would use in your own practice or colleagues use?
Yes.
Okay.
If we're working with a patient who's, we have a consultative arrangement with psychiatrist and a care coordination, our portion of that participation would be billed using those codes.
Ben, I believe those are included in the code set, the collaborative care codes.
Good.
Also, Dr. Bernstein had another comment in the chat that I think is of interest, and one you may want to highlight, which was that a lot of the behavioral health care that is provided by primary care is, just through a 992 visit and other sort of services. And so it may at some point be of interest to just look at the primary care core set and look at that by diagnosis to see, what percentage of those are for anxiety and depression, et cetera.
No, that's a good point. It's my understanding that, that's what Dr. Bernstein described is not only done in primary care, but is also occurs frequently in psychiatry today, that 2 codes are billed as opposed to one being a standard E&M.
It was intended to be somewhat responsive to Mr. Miller and his concerns.
Thank you. Ken, back to you. I think you've about covered what you wanted to cover. Is that right?
We just have, let's see for the next slide, continuation of this. Next slide, please. And then these are the behavioral health provider specialties.
Again, affiliated.
Affiliated, yes.
Okay. All right.
Slide, please. And then we go to the OBGYN services. And these are services that are provided by a primary care provider.
Okay, Ken.
And then next slide, please. This is a continuation of those lists of services.
And again, it might be just for the groups, education on this that would provide a distribution. I suspect a much smaller number of codes are actually going to be appearing. And again, this is OB/GYN services provided by a family or a primary care provider. We're not looking for an affiliated provider, OB or GYN provider, but rather the primary care.
That's correct. Next slide, please. And these are just the other technical notes on the data, from ECD to note if anyone is interested.
Okay. So I think I'm going to, am I now passing this off to Melanie?
That's correct.
Yes, thanks.
And Amy.
So and then do you mind bringing up the next steps slide?
Did we lose her?
Did we lose her? No, she's there. So now I'm just going to go over some next steps based on the conversation that we've had over the past few meetings. So MHCC greatly appreciates all the work group members' input in developing the primary care definition that will be used to track primary care spending. The initial results were shared at today's meeting. So prior to us finalizing the definition, interested work group members will have an opportunity to review the full code set and suggest any refinements. So next, the work group will provide input on whether to develop a target for primary care spending, and if so, how to set that target. So this information, along with previous discussions on measuring progress towards primary care goals, will inform the report and plan provided to the governor and the General Assembly later this year. So happy to answer any questions on the next steps.
So before we open it up to the group, I just wanted to make an observation, I think, is that we went through this process in a bottom up, build this up, inductive type thought exercise, which I think has been very instructive for the MHCC staff, and I hope it's been useful for the work group members. But it also has highlighted a direction that I think we're going, which is to be disciplined and pretty cautious about over defining primary care, partly because I think we're taking everyone's input into that, but also we are recognizing that this work has a political edge to it. And if we broadly define primary care and we come out with a report that says, 12% of healthcare spending in the commercial market is for primary care services, I think it's going to be harder to set a threshold above that without getting, some reaction from some groups. And I don't even know exactly who they might be that says, well, 12% seems about right to me. And so I think we've been trying to follow the direction of the work group in terms of the definitional framework that we've taken on. But also, I think we're recognizing with, in mirror fashion that over defining primary care may conflict with our overall, I think everyone's objective of recognizing that we want to elevate and encourage further investment in core primary care providers and core primary care services. So I think it's appropriate, we've been through 4 meetings now, kind of to give that, as a direction that we're headed. If, folks have some concern about, well, maybe we want to emphasize, a broader definition, happy to, to have those discussions. But I think, what we've done has been consistent with the direction that the work group wanted to go, but it's also been an attempt to be mindful of, we don't want to call everything primary care, because I think that risks conflicting with our overall objective of elevating investments. So I'll leave that for everyone to contemplate, for our next meeting, but happy to stop here and get other people's input as well. Okay.
Hey, Ben.
Yes.
Hey, it's Nora. I just wanted to say, I think from the standpoint of, if we could step back just a little bit and ask the question, what does a healthy healthcare system look like? And that may be looking to other countries and looking at the percent spend in primary care, even if we didn't define it exactly the same way. I think trying to get at what that looks like, just to have a couple of different benchmarks out there, it could be very helpful.
Sure. Other suggestions? Dr. Barr? Okay. All right. Back to you, Melanie.
So our next meeting, as I mentioned earlier, is tentatively scheduled for May 2nd. At this same time period, everyone should have the invitations on their calendar. If you don't have an invitation from us, please let me know. And we will be following up with some of the documents that we mentioned today. And David, did I miss anything? Is there anything?
The only thing I would note is please hold the May 2nd as tentative, and staff will be getting more information out regarding that meeting in the next several weeks.
And as always, we post the recording, the meeting materials, and a very brief meeting summary onto the MHCC website for the work group.
And great discussion.
And we do have, we are working on Medicaid primary care spend, and our colleagues at HSCRC is working on calculating measures for the Medicare population as well. So just in terms of thresholds, it's very likely that primary care spending targets are going to be payer specific, given the nature of utilization for the respective populations. Medicaid and the commercial markets are probably going to look more similar than what we might expect for the Medicare population, but stay tuned on that. And we'll be making those presentations to you over the course of May as well. Is that, do I have that correct, folks?
Yeah, that's correct.
Okay. All right, well, I want to thank everyone for participating today. The slides should be now available on the work group website, and naturally, if you have further questions, by all means, reach out to us, and we'll work with you to get answers or convene some additional meetings to clarify any questions that are outstanding. I want to thank all the staff from MHCC, David, Ken, Melanie, Anene, Ali, as well as our trusted consultant, Mary Jo, for their work on this. They were holding meetings, prepping for this on Friday, when many other people were coloring Easter eggs, is my bet. So I want to thank them, or finishing their third day of matzah.
And Ben Osei was very helpful to us as well.
Yes. Oh, I missed Osei. Yes. Osei did all of the generation of these analyses, and a big hand goes out to him as well. Sorry, Osei. I was looking across my screen here. So thank you very much, and you all have a good night.
Thanks, everyone.